We've done a lot of examinations, we've done a lot of investigations, right? So what is our definitive diagnosis after all of this? इतनी लंबी हमने किस्सा कहानी सुना ली है. What is our diagnosis and how we will treat this patient? Papilledema. So I have a definitive diagnosis. Does anyone concur with this diagnosis? या कोई मसला है इस diagnosis में? Please mute your mics, everyone. Mics mute कर दें खुद ही, वरना मैं mute कर दूंगा. So your definitive diagnosis is papilledema. Why is your definitive diagnosis papilledema? And why isn't your definitive diagnosis anyone of the optic neuropathy क्यों नहीं है, optic neuritis क्यों नहीं है, CRA क्यों नहीं है, CRA? And why
हेडेक की वजह से
हेडेक सारों में हो जाता है.
हमें नजर ब्रेन ऑक्यूपाइंग लीजन नजर आई है, तो स्पेस ऑक्यूपाइंग लीजन इन ब्रेन नजर आई है, तो इस वजह से
नो इन्फ्लेमेशन.
Right? It's an papilledema due to an SOL. So how should we treat this patient? And then I'll discuss the important findings and the things in this case which are important to us. Treatment. IV mannitol, IV drugs. अच्छा मैं mic mute कर रहा हूँ क्योंकि काफी शोर आ जाता है. So only unmute your mics when you have to say something. ये काफी ज़्यादा मसला है. IV mannitol, IV acetazolamide जो हम कहते हैं. Why? To reduce the intraocular pressure. Right? So these are two things which you would want to do. And do you think that this is the permanent cure? Surgery ज़रूरी नहीं है. Surgery ज़रूरी है.
सर्जरी, yes.
ठीक है. Our colleague Rebelex is saying that surgery ज़रूरी है. Surgery is necessary because if you do not get rid of the SOL, these problems can persist. IV mannitol, IV acetazolamide, they're temporary solutions. So surgery is definitive treatment. So what you have just witnessed is a case of papilledema due to an intraocular space occupying lesion. There are very much findings present इसमें काफी ज़्यादा हैं. So you have your list of differentials. Now let's have a general discussion on this. Surgery is definitive. बिल्कुल, it's definitive.
भाई हम ऑप्टिक नर्व की डिकम्प्रेशन करेंगे?
कर सकते हैं, बिल्कुल कर सकते हैं. तो SOL मूवल भी कर सकते हैं. Optic nerve decompression is also surgery. There are different types of surgeries. Optic nerve decompression आप कर सकते हैं, but there are some इसके अपने कुछ हैं caveats. There are some things which you have to consider. Optic nerve decompression means that you're decompressing a part of the nerve which is not directly under pressure. Okay, so it has its own indications. इसके अपनी, those are above our level. So you can write down that optic nerve decompression can be done for indications. आपसे कोई पूछेगा नहीं. नहीं. Enlargement of blind spot can be observed in glaucomas. It can be observed. No, it's not pathognomonic. It's not pathognomonic. Okay, that is the thing in case of disease of the optic nerves. बहुत confused कहते हैं. Okay, you can, on the basis of one symptom or one sign alone, you cannot form a definitive diagnosis and follow up on that. You need to have a constellation of signs, symptoms, and investigations to rule out diseases of the optic nerve. Okay, that is why it's important. So let's discuss what we found. Okay, so in our patient who had symptoms of 1 month history of headache and intermittent episodes of blurred vision. अच्छा, so she had intermittent episodes of blurred vision. जिसका मतलब है कि her vision returned to normal, and then she had blurriness. Now, two of our differential diagnoses down here, CRVO and CRAO. In CRVO, we know that there is subacute loss of vision, and it is complete. ठीक है, अगर CRVO complete है तो loss of vision complete है, वरना there is loss of vision. उसमें blurring नहीं होती. Secondly, intermittent episodes नहीं होते. CRAO can cause intermittent episodes. But if it's a complete CRAO, इसमें दो बातें हैं. If it's a complete CRAO, central retinal artery occlusion due to an embolism, there is sudden and complete loss of vision. That is the first thing. The second, if it's due to an embolus which passes और repeated emboli होते हैं, so that means that this patient must have something which is causing repeated embolisms. So usually embolisms are from atherosclerotic diseases. Okay? But do you think that in a patient who's 21 years old, even though she has a large BMI, okay, it's unlikely that the atherosclerotic changes have occurred. If BMI is ज़्यादा है, इनको obesity है, but her BSR is also subnormal. So it's unlikely she has had enough time for the development of such severe atherosclerotic plaques that they are causing retinal artery occlusions. First thing, जो अभी हमें हिस्ट्री से हमें थोड़ा बहुत क्लू मिल रहा है. अच्छा, let's move on to the physical examination. Blood pressure is important. Why is blood pressure important? Again, this is question is specifically for those people who have done retina. Okay? You know that बिल्कुल malignant hypertension. बिल्कुल malignant hypertension की तरह होता है. And you know that in malignant hypertension there is severe disc edema, there are hemorrhages, arterial changes होती हैं, EV changes होती हैं, but disc edema, hemorrhages, spots, they are present in malignant hypertension. So we have to rule malignant hypertension out as well. So her BP is normal and she does not report using any hypertensive drugs. So it's unlikely that she has malignant hypertension. Visual acuity is decreased. ठीक है, it's a sign हमें थोड़ा बहुत अंदाजा हो रहा है. Tonometry is normal. So discuss this happen because if tonometry is normal and an angle is open, there are no signs indicating previous closure. This means that this patient does not have acute angle closure glaucoma, and secondly, she is not a suspect. Suspect भी नहीं है, and she is not does not have subacute attacks. अगर हमें फिर भी clear ना होता, and if this was vague, we would have performed anterior chambers OCTs or ecto investigations, which we discussed in glaucoma, right? The pupillary reflex is normal. This is a very important finding. And this essentially is one of the differentiating features of papilledema from the other two. The pupillary reflex being normal. Okay? Pupillary reflexes are not normal in optic neuritis. They are not normal in optic neuropathy. On slit lamp, eye movements, CN5 is affected. Why is this happening? Okay, why is this happening? Why is
compression हो रही है as well?
ठीक है, बिल्कुल. So that nerve, the cranial nerve 6 nerve, can be compressed due to space occupying lesion, or due to the raised intracranial pressure, this nerve can be compressed. So we have two manifestations. Okay, this papilledema is a manifestation of that as well. So is the 6th nerve palsy. We have a manifestation. Now, slit cup examination, there are biodisc lateral edema, blurring disc margin, soft exudates, similar dilated veins. These are the normal findings you will find in papilledema. But a very important clue is that they are bilateral. Okay, they're not unilateral. So, on the basis of these few things, we can have our diagnosis of papilledema. Perimetry shows unspecific findings. Okay, a large blind spot, we know that optic nerve is involved. FFA, leaky vessel is all right. There's congestion happening. CT, MRI shows an SOL. Okay, why only 6th nerve and why not 3rd and 4th? It's a very good question. Okay, if anyone knows the answer, बता दें and I'll tell.
Because level of the midbrain पर होता है 3rd and 4th cranial nerves, oculomotor और trochlear, और जो होती है उसका level होता है I don't remember, लेकिन level change होते हैं brains का.
ठीक है, level change होती है. So I'll tell you why these are happening. Concepts are right. It's good. The 6th nerve. 6th nerve का क्या नाम है? It's the abducens nerve, right? So abducens nerves has a very peculiar course. It is the nerve which is somewhat most affected when there is raised ICP, or if it has a direct there's a direct pressure effect. So raised ICP के अंदर 3rd nerve palsies भी हो सकती हैं, 4th nerve palsies भी हो सकती हैं. It's not necessary कि parietal lobe की lesion के अंदर ही हो, raised ICP की वजह से हो सकता है. ठीक है? So it's good. You can also find the 3rd nerve palsy. Especially with 3rd nerve palsy भी हो सकती थी. You could have found the 4th nerve palsy. but sixth nerve palsy due to the location it's commonly involved. ठीक है, fourth nerve सबसे ज़्यादा वो कहते हैं. So you have good concept. Any of these nerves can be moved. अच्छा, so we find these findings. Now the question is, why do these happen? A little bit about the pathophysiology. Why do you think these changes are happening? ठीक है, हमें पता लग रहा है कि सिक्स नर्व पैरालाइज्ड, ओके, डायरेक्ट इफेक्ट हो सकता है, आईसीपी रेस्ट हो सकता है, सिक्स के अलावा थ्री भी इन्वॉल्व हो सकती है, फोर भी इन्वॉल्व हो सकती है. बट व्हाई आर वी सीइंग दीज फंडोस्कोपिक चेंजेस? Why are we seeing normal pupillary reflexes? Why are we seeing, चलो ये तो हमें पता है कि why this is a notch blind spot, but why are we seeing these changes on fundoscopic examination?
रेस्ट आईसीपी की वजह से कैपिलरीज पे कंप्रेसिव इफेक्ट होगा तो एडिमा डेवलप हो सकता है.
ठीक है, that is good. That is good concept. So let's see our findings. There's disc edema or blooding of disc margin. There are soft exudates. Soft exudates are also called cotton wool spots. And those who have studied retina, they know that cotton wool spots are due to what?
Nerve damage.
Nerve damage. They are due to the stopping of exoplasmic flow. So if you look closely, जो ये brown line बनी हुई है, this is actually the meninges, because the eyes are extension of the brain, and the meninges, they are also extended up till these levels. This is the optic nerve. अब होता है क्या है, if the ICP is raised, मतलब CSF यहाँ पड़ा होता है ना, this is the submeningeal space or subarachnoid space, so I इसकी nerve sheath की बन रही है. Since ICP is raised, pressure is over here, it is causing a direct compressive effect on the optic nerve. This raised ICP all along the pathway. It will lead to two things. Okay, first, the optic nerve is being compressed. This compression of the optic nerve will lead to a stop in exoplasmic flow. और exoplasmic flow का stop होगा, जिसकी वजह से these nerves, they will swell up. ठीक है, they will swell up. इनकी swelling हो जाएगी. And they will have those soft exudates as well. That is the first thing which happens. There is a stop of exoplasmic flow. Secondary, the vessels are being compressed. Now, the thing about vessels is that the arteries, they can, due to their pulsations and due to the higher pressure, they can keep open, but the veins, they collapse. अगर vein यहाँ पे collapse कर जाती है, और artery फिर भी खुल गई, it means that blood is coming inside the eye, but it's not going out. और कभी-कभी आ रहा है due to the pulsations, high systolic pressure है उसकी वजह से pulsations आ रही हैं. Generally, the arteries will be attenuated because of this blockage, and because the venous drainage cannot occur, these vessels, they will become tortuous as well. Okay, they will become tortuous. Or due to this tortuosity, what will happen at the disc? This is the disc. This swelling will become even greater. What will happen is that the normal optic disc, which is present over here, it will be obliterated. Okay, ये जो normal optic disc है, this is the optic disc, right? And this is the cup. It will be obliterated, and there will be papilledema or a raising of the disc. That is why the disc is a disc appeared raised. Aneurysm, compression too. These things, they happen. So there are two pathogenesis. Those की pathophysiology. First, due to the compression of the vessels. The second is due to the stop in exoplasmic flow. These are the two reasons due to which ग्लूकोमा में हमने डिस्कस किया था कि कपिंग बढ़ जाती है. दिस इज द ऑप्टिक कप ना, तो कपिंग ज्यादा हो जाती है अंदर. इन पैपिलेडेमा the opposite happens. Cup is obliterated and the disc, it swells outward. So when it swells outward, there comes a difference from the normal retina. This is the normal retina, and the outward bulging disc, or the optic disc head, optic nerve head. This difference, according to your text in papilledema, is around 6 to 8 disc diopters. Meaning there is massive bulging of the disc. यानी कि इतना फर्क है नॉर्मल रेटिना में और ऑप्टिक डिस्क के हेड में, 6 to 8 disc diopters. Why is this difference necessary? It's an important point जो हम discuss कर रहे हैं. So briefly summarizing this case, because we have one more. Patient of papilledema will have these symptoms: visual loss, blurring of vision, headaches, मतलब due to raised ICP, because most likely papilledema is due to ICP. They will have normal pupillary reflexes. The changes, including disc edema, blurring of the disc margin, soft exudates, hemorrhage, dilated veins, they will present bilaterally. Okay. And on the basis of these things and on the basis of investigations, we can form a proper management plan and a proper diagnosis. Now, two things before we move on to our next case. IOP क्यों रेज नहीं हो रहा? So IOP raise होने के लिए pressure it needs to increase inside the eye. So when the disc it bulges, it's actually bulging due to the increase in pressure over here. इस यहाँ pressure increase हो रहा है उसकी वजह से bulge आ रहा है और जब ये pressure ज़्यादा बढ़ेगा तो what will happen is that retinal veins they will उनमें pressure बढ़ेगा, they will start to rupture. उसकी वजह से आपको hemorrhages नजर आना शुरू हो जाएंगे, उसकी वजह से hard exudates नजर आना शुरू हो जाएंगे, उसकी वजह से बाकी signs नजर आना शुरू हो जाएंगे जो retinal vessels के होते हैं. उसके बाद जाके हो सकता है this initial change is small enough, is small, it's very small to cause a sudden raise in intraocular pressure. Okay, what can happen? It is actually increasing the pressure at the disc. और अगर ये ज़्यादा होगा तो इसके बाद चेंजेस वेसल्स में आएंगी और वेसल्स के बाद के चेंजेस जो हैं अगर वो फिर भी कंट्रोल नहीं होती फिर भी बहुत ज़्यादा रहती हैं तो वेसल्स के बाद चेंजेस मतलब वेसल्स के बाद चेंजेस इंक्लूड रप्चर ऑफ द वेसल्स, हेमरेजेस, सब रेटिनल हेमरेजेस और फिर उसके बाद प्री रेटिनल हेमरेजेस आ जाएंगे एंड देन देयर कैन बी एन इंक्रीज इन इंट्राओक्युलर प्रेशर. ठीक है. In glaucoma, the intraocular pressure is a cause of disc damage. Over here, there is something else which is causing pressure on the disc, और वो pressure पीछे से आ रहा है. That's why the disc is bulging forward. I hope I've answered the question. What is DD diamond? Disc diopter. Disc diopter. ये थोड़ा सा होता है. It's different. Disc diopter is actually a measurement term जो retina में I'll discuss with you again. It's used to measure मतलब डिस्टेंस मेजर करने के लिए यूज होता है. इसकी थोड़ी यूनिट्स होती हैं. आई थिंक माइक्रोमीटर्स में इसकी कन्वर्जन है. 1500 माइक्रोमीटर्स एक डिस्क में होता है, समथिंग लाइक दैट. नॉट श्योर एट द मोमेंट, मुझे भी पढ़े हुए काफी अर्सा हो गया. वी विल डिस्कस दिस व्हेन वी मूव ऑन टू रेटिना. There are two questions I would like to ask before we move on to our next case. The first thing is, do you think that papilledema can be unilateral? Meaning that let's just say the left eye is normal, okay, and changes are only present in the right eye. Can you name one condition in which this can happen? Okay, so yes, it can happen. If there is anything which is causing compression of the optic nerve which is present in the eye, for example, there's a glioma, a tumor of the oligodendrocytes or the nerve cells, neuroma, etc. Any tumor, it can cause optic disc compression. It can lead to papilledema. Even in severe orbital cellulitis, उसमें unilateral आपको papilledema मिल सकता है. Costa-Kennedy syndrome is another important syndrome. It's not that high yield, but if you read it, it's good. So these changes can occur unilateral as well. One other question. Let's just say that on CT scan, we found nothing on the patient. Okay? CT scan was normal. And when we perform a lumbar puncture of the patient, her cerebrospinal fluid pressure was increased. CSF increase है, CT scan or MRI brain imaging में you find no space occupying region. The diagnosis will still be a papilledema, but the papilledema will be due. Hydrocephalus करीब है. Hydrocephalus it occurs in children or when the brain has developed. Adults, it can be choroid plexus tumor हो सकता है. तो
benign intracranial hypertension.
Benign intracranial hypertension. Idiopathic intracranial hypertension or pseudotumor cerebri. Pseudotumor cerebri or benign intracranial hypertension. Actually, benign intracranial hypertension का case था that it's common in women of this age and common in obese women as well. Other confusing हो जाना था start में, that is why I thought this one. This was our first case.
मुझे ये बात अभी तक समझ नहीं आई कि एक साइड पे में सीटी स्कैन में वो स्पेस ऑक्यूपाइंग लिए नजर आई है, तो फाइंडिंग्स दोनों साइड्स पे मिल रही हैं.
क्योंकि देखो जो सीटी स्कैन दरअसल थिंग इज कि ये ट्यूमर डायरेक्ट कंप्रेशन भी करा सकता है। दूसरा है कि ये ट्यूमर इंट्राऑक्यूलर प्रेशर इंट्रासेरिब्रल प्रेशर रेस कर रहा है, ठीक है। तो सबरेटिनल फ्लूइड सबरेटिनल स्पेस के अंदर सेरिब्रोस्पाइनल फ्लूइड पड़ा हुआ है ना। अब ये ट्यूमर आ रहा है, यू नो दैट द ब्रेन इज क्लोज्ड, हड्डियां, इट्स अ क्लोज्ड वॉल्ड, नथिंग कैन कम इन और अमाउंट में अकोमोडेट नहीं कर सकता ये चेंजेस। When
ठीक है,
mass
सही
is
है।
growing inside, that pressure is transmitted to the eyes because we know that eyes are extension of the brain and they have the same meningeal layers. जो subarachnoid space brain के अंदर है वो इसी नर्व शीथ के अंदर यहाँ तक मौजूद है। तो दोनों नर्व शीथ्स के अंदर है और जब प्रेशर अंदर बढ़ रहा है तो वो इन नर्व शीथ्स के जरिए इधर तक ट्रांसमिट हो रहा है। That is why it is causing these changes. So let's move on to our next case. Read this carefully. इसमें symptomatology काफी ज़्यादा है. There are a lot of symptoms in this. Read them carefully. Then we will try to work up this patient the same way we did our first one. So let's see the case. A 40-year-old female presents to us with cloudy vision of the right eye. So symptomatology tells us that she has cloudy vision, blurring vision, कुछ भी हो सकता है, it's a vague term. But the thing is that it's present in one eye. It is unilocular. Uniocular, not unilocular, uniocular. That is the first thing which we have found out. Okay, she has symptomatology which is uniocular or unilateral. 40-year-old female who was well until 2 weeks ago. So it's not acute, it's not chronic either. मतलब सब acute period में आ रहा है because acute means के days to weeks, मतलब days to first week. chronic का मतलब है कि सालों या महीनों में चला रहा है. It's 2 weeks, so it's in between. ठीक है. When she noticed visual loss in her right eye, she's noticed visual loss in her right eye. ठीक है. Accompanied by pain with movement and a dull retroorbital ache. Pain with movement of eyes and dull retroorbital ache. These are two important symptoms. She also noted decreased perception of color and contrast. It's a very strange symptom. अभी तक हमने पढ़ा है किसी भी जगह पे decreased perception of color and contrast? I don't think so. हमने अभी तक नहीं पढ़ा. She denied double vision or headache. What does this tell us? Double vision or headache?
Papilledema, intracranial pressure rise.
ठीक है, वो एक सिम्टम होता है ना उसका, तो एक सिम्टम नहीं है उसका, फिर भी हो सकता है, बट वन सिम्टम लेस. डबल विजन नहीं है, स्ट्रिबिस्मस नहीं है, तो उसका मतलब ये है कि her eyes are good, she doesn't have squint. That's the first thing. She recalled one episode of similar blurred vision in the left eye 1 year ago, which resolved spontaneously. Now, this is a very strange statement. Okay, I find it very strange that the current symptoms are in the right eye, but she had a similar episode in her left eye 1 year ago, which resolved spontaneously. On the basis of symptomatology, we can see a lot of things in this case. A cloudy vision in the right eye कुछ भी हो सकता है. हम examination करेंगे तो पता लगेगा ना. Pain with eye movements and a dull retroorbital ache. So this is somewhat localizing. Eye movements में pain हमने एक और disease में पढ़ी थी. Can anyone tell which disease it was? Panophthalmitis. Panophthalmitis में हमने pain पढ़ी थी, ठीक है? Pain on moving the eye. But it's unlikely she has panophthalmitis because one, there's no history of orbital cellulitis or sinusitis, and two, she does not have any history of endophthalmitis or any infection of the eye. at least in the preceding period. एक साल पहले कुछ हुआ था उन्हें, but it's unlikely कि एक साल पहले एक आंख में हुआ है और दूसरी आंख में panophthalmitis होता है. Similarly, orbital cellulitis भी इसमें भी painful movements होती हैं. दोनों differences are unlikely. So we've ruled out two things based on the history alone. और because अच्छा चलो कर लेते हैं आगे. What how do you think we should examine work up this patient? वर्कअप हम कैसे करेंगे इस पेशेंट को?
विजुअल एक्यूटी,
विजुअल एक्यूटी
जनरल फिजिकल एग्जामिनेशंस में भी करेंगे.
बिल्कुल, जनरल फिजिकल एग्जामिनेशन हम परफॉर्म करेंगे. तो ऑक्यूलर एग्जामिनेशन इज इम्पोर्टेंट, a general physical examination is important, and then we have some investigations which we need to perform. Let me write it down first. General examination, ठीक है. जनरल फिजिकल एग्जामिनेशन में मैं कहूँगा GPE is unremarkable. For the sake of simplicity, I'm writing unremarkable. लेकिन 40-year-old patient कुछ भी हो सकता है ना. He could have heart attack, he could have diabetes, atherosclerosis. The reason I'm writing unremarkable is here because in our classical cases, textbook cases, we don't want to be confused in different things. GP is unremarkable. GP करवा दिया. This includes every investigation or examination you could think. Ocular examinations. Which are the ocular examinations which you would like to perform?
Perimetry.
Perimetry. भी लाइकोटी नहीं करेंगे, पहले perimetry पहुंच जाएंगे. Visual acuity is 20 by 24 times. अब आप बताएं आगे क्या करना चाहेंगे.
Color vision?
Color vision. How do you check color vision?
Ishihara's chart?
Ishihara's chart, right? You can use Ishihara's charts, or you can use different. I'm not sure of the instruments. They are a flicker test or something like that. So Ishihara's chart or a flicker test, these things they can be used. On ocular examinations, you find that she has decreased red sensitivity. That is the first thing you find. She has decreased red sensitivity when you perform a detailed color chart examination. It's an actual investigation. I'm correlating the color chart in Ishihara's way. We're not able to quantify it that much, but since you've mentioned it here, I'm writing it down over here. So we've checked her color vision. Anything else you would like to do or perform in this patient?
Pupillary reflexes.
So pupillary reflexes. You want to perform pupillary reflexes on this patient. Okay, pupillary reflexes, she has an RAPD, a relative afferent pupillary defect in the right eye. Okay. It's low. There's a relative afferent pupillary defect in the right eye, but in the left eye you don't find no RAPD or normal in the left eye. What else would you like to perform in this patient? You found out that she has relative afferent pupillary defect. Extraocular movements, okay? Extraocular movements. Reflex frontoscopy. Yes, a frontoscopy will perform a frontoscopy. You will definitely perform. First, you perform a extraocular movements. They're painful, but normal. They are painful. They are full, but there is pain. Pupils आपने देख ली है, activity आपने देख ली, motility देख ली. State lamp examination से पहले कोई 2-3 चीजें अगर आप करना चाहें. Tonometry is important. There's a lot of things you need to rule out when investigating it. And performing a tonometry, IOP is normal, both sides. स्लिट लैंप एग्जामिनेशन करें या और कुछ आप करवाना चाहेंगे? So, perimetry. Perimetry, confrontation perimetry is clinical. The other perimetries are investigations. Perimetries, they are unremarkable. There are some changes which you think there are some changes present, but it's unremarkable. You cannot find something of note. Perform a slit lamp examination after this. So when you perform a slit lamp examination, the anterior chamber is normal and the anterior compartment is normal. But when you perform a frontoscopy, this is what you are seeing. इसको मैं जरा थोड़ा नीचे करूं. Is anything abnormal in this retinal examination? What are the abnormalities? क्या findings आप pick कर रहे हैं?
Blurring of margin nasal side पर.
Okay, so you think that there is a blurring of margin. ठीक है. Or what else do you think? This is the nasal side. What are the findings?
Dilated
The veins are dilated. ठीक है. The veins are dilated. All right. और क्या है? क्या है इसमें?
CDR?
Cup disc ratio. Cup disc ratio. We cannot exactly appreciate the cup disc ratio, but we cannot see any bionetting. We cannot see any nasalization of the vessels either, and there are no hemorrhages or disc edemas. So it's unlikely that the CDR increase. क्योंकि CDR increase कहते हैं जितना CDR increase करेगा उतना vessels nasal side पे move करती जाएंगी. थोड़ा सा correlation है आपस में. because कब बढ़ेगा तो vessel side पर होंगी. The vessels are there in the center. It means that the cup disc ratio is normal. Since nobody can pick up any findings on this retinal examination, it's normal. This retinal examination is unremarkable. So you have an unremarkable endoscopic examination. Badi cheap baat hai. When you examine this patient, you cannot find anything. There's no palate, no edema. The cup disc ratio is normal. The macula was normal. Vessels normal. Everything was normal. It's normal. Any other examination you would like to do?
lumbar puncture.
Lumbar puncture. But why would you want to perform a lumbar puncture in this patient?
अभी तक कुछ नजर नहीं आया तुम्हें प्रेशर वगैरह ज्यादा हो जिसकी वजह से
बिल्कुल प्रेशर में ज़्यादा हो सकता है. You're right, प्रेशर वगैरह ज़्यादा हो सकता है. But if pressure were to increase in both in her brain, wouldn't you see disc edema, papilledema, those findings which you picked up in the first case? Chalo, you're thinking that, all right, pressure is low. But even फिर lumbar puncture कराने का फायदा क्या है आपको? If you cannot have these different symptoms, you don't have headache, you don't have nausea, you don't have vomiting. Yeah.
इसके थायराइड का प्रोफाइल करा.
Thyroid profile. Like to perform a thyroid profile, but she does not. चलो thyroid profile. Thyroid profile आप कराना चाह रहे हैं. This patient is otherwise unremarkable. Okay, you ask her history. आपको ठंडा गर्म ज़्यादा महसूस तो नहीं होता? She says no, I'm fine. आपको प्यास ज़्यादा तो नहीं लगती? आपका वजन तो नहीं बढ़ा? नो, आई एम फाइन। आपके दिल की धक धक की धड़कन ज़्यादा महसूस तो नहीं आती? बिल्कुल नहीं डॉक्टर साहब, एवं डिस्कम्फर्ट बेहतरीन। You don't have any stigmata of thyroid disease. You do not have anything on the symptoms as well. तो चलो थोड़ा सा आपने कहा कि चलो हिस्ट्री में अपनी सिक्योर कर लेते हैं. So when you go to the family history, you ask the patient, okay, all right, आप मुझे बताएं, is there any history of कोरोना, आपके खानदान में कोई बीमारी चल रही है anything like that? Now she tells you that her sister suffering from MS. MS क्या है? Does anyone know what is MS? Multiple sclerosis. बिल्कुल, multiple sclerosis. ठीक है, sister has multiple sclerosis. ठीक है, she's suffering from multiple sclerosis. एक ही दवा पता लगी हिस्ट्री में. तो now investigations, examinations. Any of them examination you would like to perform? Shan says we would like to do an MRI. Is there anyone else who would like to perform an examination?
Scan.
चलो हम अभी कर लेते हैं. So B scan, अच्छा, B scan is done when you cannot see behind the cataract, behind an opacity, behind anything which is occluding the vision of the retina, and you want to know if the retina layer is structurally normal. So since we can see the retina and we're not performing a cataract surgery, we do not have any indication to perform a B scan. हमें जरूरत नहीं है B scan करने की. Unlikely हम पैसे ज़ाया करने वाली बात है. In order to have a good list of investigations, you must have a good list of differential diagnoses first. Okay? A fluorescein angiogram, again, you're not seeing any edema, you're not seeing any any vessel congestion, you're not seeing any hemorrhages, you're not seeing any exudates, soft exudates, hard exudates. So based on that, it's unlikely that the retina is involved. First, we should have some differentials, right? We should have at least some differentials. हमें पता है कि FFA हम कब करवाते हैं? We perform in macular diseases, we perform choroid diseases, disc nerve edema में भी करा सकते हैं. I wrote it down कि हम यहाँ पे करा सकते हैं, but जो चीज़ें आपको नजर आ रही हैं, अगर आपने उसकी quantification के लिए नहीं करवाना, तो why are you doing that exam investigation? Because you're seeing those things. ना FFA भी आपको ही बता रहे हैं कि leaky vessels हैं, dye leak कर रहा है. You can already see that the vessels are leaky. There's hemorrhage. So you must have a differential in your mind first when you're looking towards investigation. So Shan has might have a differential in his mind, and he's saying that we should do an MRI of the brain. So कोई और investigation आपके ज़हन में आ रही है? You think we should?
Yes, sir.
क्या करवाना चाहिए? All right. So
Yes, sir.
genetic cause, right? You have a genetic cause. So when genetic cause बिल्कुल हो सकता है. I'll इसके बारे में आपसे डिस्कस करता हूँ. Color blindness हो सकती है, right? Color blindness हो सकती है. So you're suspecting that this patient has red blindness. Red blindness is I called tritanopia या कुछ opias हो सकते हैं. You would like to perform an ESR. You know, Maham has picked something up. That's where we should perform an ESR. Color blindness हो सकती है, but a color blindness will not present with all of these symptoms. मतलब if she has color blindness, I have two friends who are color blind. उनको मतलब green नजर नहीं आता. Color blindness does not have pain with eye movements and dull red properties. So even if this person has color blindness, they have something in addition to it. So